This is working now. I just did some time where it said it was going live and it doesn't look like it ever connected to the internet. So anyway, we're finishing up chapter 7, stuff on adolescence. And this is when a lot of the trauma can kick in that I wanted to go over. First round is this cartoon that I wanted to show you because it's a little easier to understand. But something you could give a presentation on.
You know the old saying, don't judge a book by its cover? Well, the same is true when you assess a patient. Hi, I'm Dr. Cruz. Early in my career, I noticed a pattern with some of my patients. They often had multiple health issues, were uneasy during office visits, and frequently visited the emergency department. But worst of all, they never got better despite multiple visits. Then I realized something. From an early age, many of my patients were exposed to trauma and adverse childhood experiences, or ACEs. This includes emotional, sexual, or physical abuse, violence, neglect, discrimination, poverty, and other adverse events. ACEs are more common in the US than you'd think. In fact, 60% of US adults have one ACE, 25% have 3 or more ACEs, and 16% have 4 or more. ACEs occur in all socioeconomic groups, but are more common in low-income and minority populations. For young children, repeated exposure to trauma can impact brain development and literally rewire the brain's response to stress. So as they grow up, many struggle with issues related to emotional regulation, like depression, anxiety, or substance use disorders. Trauma survivors are also more often at risk for chronic diseases, behavioral health problems, and even suicide. Knowing all this, I began to rethink my approach to care. Instead of asking patients, "What's wrong with you?" I ask, "What happened to you?" Recognizing that life experiences are often a root cause of poor health is integral to improving patient care. Trauma-informed care has helped me take these experiences into account, providing greater insight into my patients' needs and how to address them. Here are 5 key ways that healthcare organizations can gradually integrate trauma-informed care into their practices to help patients and staff. First, build awareness and generate buy-in. Involve both staff and patients in adopting a trauma-informed approach. Second, invest in a trauma-informed workforce. Hire staff that embrace trauma-informed care and provide training not only for clinical staff, but also for non-clinical employees like front desk workers or security guards, who are often the face of your organization. Next, create an environment that is safe and welcoming for patients and staff. Engage patients in meaningful ways. Ask how they feel and listen. You can also build trust by involving them in their own treatment planning. Finally, identify and treat trauma. Consider a screening approach that works for your patients and ensure that treatments and referral sources are available. These changes take time, but each step improves our ability to connect with and care for patients. Today, our patients appreciate the changes we've made. Plus, our staff is more in tune with patients, so work is less stressful and more rewarding. Trauma-informed care. It can truly transform the caregiving experience from being treaters to being healers.
So there's some of the stuff that comes up with trauma. Important to consider for or doing adolescence. So the next one I had was as a social worker, you can become a certified clinical trauma professional. So here's what that would look like.
Welcome to Trauma Competency for the 21st Century. This is a certification course. It's presented in 21 different modules, and I'm excited to get to bring it to you. My name is Eric Gentry. I want to talk just a little bit about my bona fides and introduce you to me and me to you. I've been doing this for a long time. I started in 1997 at Florida State, where I was doing my doctoral work with Charles Figley, and we started the Traumatology Institute at Florida State, and won Continuing Education Curriculum of the Year that year in 1997, and trained a lot of professionals from then until 2001. And then in 2001, Florida State decided they didn't want it anymore, so I took the Traumatology Institute to the University of South Florida in Tampa with Michael Rank, and we were the co-directors of that program. And it was called the International Traumatology Institute. And we trained, developed several new and different programs there. And then in 2006, that University of South Florida decided they didn't want it anymore. And then in 2009, with a couple of other counselors and psychologists in Sarasota, Florida, we started the International Association of Trauma Professionals. And then in December of 2016, I moved here to Arizona to work with Bob and have become the vice president of the Arizona Trauma Institute and Trauma Institute International. Arizona Trauma Institute is the training arm of our organization, and the Trauma Institute International is the certification arm. I've been published in many different journals. I've worked as an academic for a little while. Have been principal investigator on funded studies with traumatic stress. So I've got all those bona fides. But the thing that qualifies me the most to sit here in front of you and to present this course is I've survived 35 years of clinical practice. And that's the way that this course is presented. It is from a clinician to people that are sitting across from trauma survivors. And as we go through this course, you're going to find that I think that there's right at 400 citations for this course. It's well have been deep in the literature, have plumbed the science of the treatment of traumatic stress pretty thoroughly. But if I have a gift, and what this course is kind of about, is taking all of that evidence-based practice, taking all that science-based practice, and turning it into, what do you do when you're sitting across from somebody who is in so much pain they want to die? How do you practice evidence-based treatment when somebody is talking to you about that, they are not safe, that they are thinking thoughts of suicide? And so that's what this course is about. And it's a march through the treatment trajectory of treating traumatic stress. And we're going to go soup to nuts. We're going to underpin it. The first part of this course is underpinning it with some concepts and some understanding. And then it just becomes a clinical course. It's about kind of how to manage stepwise the treatment trajectory of somebody that has post-traumatic stress, to accelerate that and to make that as expedient and painless and relational as possible. This is the first time in the history of the diagnosis of PTSD that I can sit here in front of this camera. Usually I'm in front of an audience, but I can say it to you watching this at home right now, that the successful resolution of traumatic stress is simple. It's never going to be easy. It's always going to be some of the most arduous clinical work you can undertake. Any of you have been doing this work for more than 10 years, you've understood that you cannot survive treating folks who are trauma survivors at the same level of professional and spiritual and personal resilience, maturation that you were launched from your graduate training programs with. You've had to evolve, you've had to grow, you've had to become a more resilient practitioners just to tolerate sitting across from folks who have been hurt badly by the environment, by their lives. It's not easy, but it is simple. And I'm going to show you, as a result of what we're going to do here in some of the early part of this training, I'm going to show you how when you complete three and a half, sort of, complete 3 therapeutic tasks using 4 different things to do to complete those tasks. When you complete 3 therapeutic tasks, your clients no longer meet diagnostic criteria for PTSD. So if you only have to accomplish 3 things, that's pretty simple and straightforward. And as we move further into the 21st century, more and more evidence is building that the better that we stay on the track of completing those 3 tasks, the better quality of outcomes from our treatment. This course is the ability to use and to become graceful and elegant and competent and moving towards mastery and excellence using cognitive behavioral therapy for the treatment of PTSD. But what you're going to find, the application of cognitive behavioral therapy is it's going to be cognitive behavioral therapy with a heart and a soul. It's going to be cognitive behavioral therapy that is deeply entrenched and ensconced and nested in a relational process. So, one of the reasons why I love doing this training, and I still continue to travel around the country and do it, is that I get, 20% of the folks that take this course, I get emails from them telling me that this course has not only transformed their clinical practice, it's transformed their lives. And that's pretty heady. I'm a junkie for transformation. That's why I work with trauma. Those of you who've been doing this work for a while, you know that when you're working with trauma survivors, you are working with the people who are the ripest for transformation. And when you do trauma therapy right, that's one of the things you get to bear witness to is people's lives transforming. And that's what makes all this work worth it for me. And for those of you who are interested in being more graceful, more efficient instruments of transformation in the lives of your clients, then you are watching the right screen right now. But for those of you that don't give hella beans about being instruments of transformation, and you just want some ways to be able to treat your clients more effectively and to make your work less painful, then you're also watching the right screen. Hopefully, if I do this with any sense of elegance, we're going to be able to stand in both of those 2 camps of where it is the acquisition of skills to be able to be good technically working with trauma survivors, but it's also going to be the professional maturation of a trauma clinician. So both of those are going to hopefully get married in this course. Just other couple of preamble things that I'd like to do. I would invite you right now to, you have a package of handbook for this course, and it has a syllabus, and it walks through all of the learning goals and all of the certification criteria for those of you that want to move this on to certification. And it goes into each of the certification criteria.
All right, so as you see here, getting certified in trauma is a distinct possibility. Something we did at Lighthouse that does help you serve your clients better. And we were going over the growth spurt, how like girls are bigger than boys. And then when puberty hits, there's the growth spurt, maturation of physiological mechanisms and secondary sex characteristics. So for boys, as production of sperm, development of sex organs, hair growth in pubic areas, underarms, chest, face, shoulders and back, skin becomes rougher, sweat glands increase production, girls, production of eggs, development of sex organs, hair growth in pubic areas underneath arms, and slight amount of facial hair, skin becomes rougher, sweat glands increase production, and then slight enlargement of breasts known as breast buds. So for girls, menarche is the cyclic shedding of the uterine lining 2 weeks after ovulation. And that is for girls, if you get pregnant, there is not the shedding of the uterine lining, actually closes and then the baby goes. But if there is no pregnancy, that's when the shedding of the uterine lining happens. Boys could have nocturnal emissions and facial hair may go unnoticed. Secular trend, onset of puberty getting earlier over the last 100 years. So in 1840, it was 17, and in 1920, it is, well, it says now it's 11 and a half years. And some, again, argue that's from us drinking milk with bovine growth hormone in it and different things we are exposed to. So something to consider. Hormones, both estrogen and testosterone, are produced about a year before the changes in the body and sex organs are visible. So testosterone in boys, as you can see, goes way up to like 400 mg per dl. Even girls have a little more. It goes from like 10 up to 20, and then even kind of up to 25. Estrogen for boys, there is a little bit. It goes from like, 10 or 15 up to 20. For girls, it goes from 10 to 30 to 50, almost touching 90 at 85. So very quickly. And that is stuff that happens early and late matures that has early boys are more athletic, successful peer relationships, and more confident. Early girls have behavior and academic problems.
Criteria and how we have drawn from American Psychological Association's guidelines for training and treatment of traumatic stress, for treatment of traumatic stress, and how to train clinicians to become competent practitioners. And it shows how we have met all of those guidelines for the APA. And it walks you through the citations for each of the modules of the certification criteria that we're going to walk through. And that's the way that this course is divided. Is that there are more than 20, somewhere probably between 20 and 25 different modules of this course that you'll be able to click on and watch the video for that piece, and then muse on that, chew on that for a little while, and read the materials that come with it, and watch the slides if you want to, and then go on to the next module. One of the things that I want to say, and I'm going to speak on behalf of my partner, Bob Roten, is, this is a business.
Oh, she did say that internship.
This is our business. This is how we pay our bills. But I am pleased and honored to be partnered with somebody who is kindred in spirit with me. This is our mission.